A very warm welcome to all of you to this PCR webinar on mitral interventions translating the new guidelines into practice. This webinar will concentrate on current evidence from randomized controlled trials and from registries on mitral interventions, how these new studies inform the new ESC guidelines on valvular heart disease. We want to enhance your practice by optimizing patient selection, who will benefit most from these interventions that we're offering to our patients. And we would also like to extend your knowledge of the state-of-the-art techniques and the huge toolbox that we have available to us right now. I'm very happy for all of you to be joining us, and I'm also very happy to have Dr. Felix Freidel here in the studio with me, and also Professor Amir Mahabadi here in the studio with me. And these are our conflicts of interest, flipping through them real fast. And Professor Mahabadi, dear Amir, I'm very pleased for you to show us some aspects of the new guidelines regarding primary mitral regurgitation.
Thank you, Mark. Let's start right away with what's new for interventional mitral valve therapy in the new guidelines. And I want to start with primary mitral valve regurgitation. On the left-hand side, you see the 2021 recommendation, and on the right-hand side, the 2025 recommendations. So what you can appreciate from the beginning that the 2B recommendation for TEER was improved to a 2A recommendation. What data is this updated recommendation based on? There's obviously no randomized controlled trial that has been published since for primary mitral regurgitation, but there's a whole bunch of registry data supporting the safety and the efficacy of TEER in primary MR. I just want to highlight a few of these data here. A large registry on more than 90,000 patients with nearly 90% procedural success rate. We see a really good reduction in MR from severe or moderate to severe in the majority of patients to no or mild, at least moderate severe MR. In most patients, and most importantly, if you compare mortality rate at 1 year for successful procedures as compared to the unsuccessful procedures, as well as the heart failure hospitalization rate at 1 year, you can really appreciate that 50% of the events can be diminished by a successful procedure. Of course, this is not randomized controlled data with all its limitations, but a successful procedure reduces hard endpoints in this cohort. If you compare procedural success rate with newer device technologies, for example, the Gen 4 EXPAND registry data, as compared to Everest 2 data, where primarily the Gen 1 MitraClip device was used, you can see how good the improvement into the reduction in MR was over the years. In Everest 2, we had 43% of 0 or +1 residual MR, which is now nearly 90% with the newer generation devices. And randomized controlled data comparing the two available therapy strategies with the Pascal and the MitraClip, you see excellent freedom from major adverse events at 1 year for both systems, with again very, very good reduction in MR, which is stable over time as well. What the guidelines also focus on is the anatomical suitability, and they also describe the characteristics, which cases are optimal for mitral TEER and which you should avoid for mitral TEER, and which this also highlights is the importance of multimodality imaging, and most importantly, three-dimensional transesophageal echocardiography to really define what's the underlying cause, the pathology of the primary MR, to decide whether TEER is the optimal strategy for this patient.
Okay, well, thank you very much, Amir. That was a great insight into the guideline regarding primary MR and interventional therapy, catheter-based. So we want to keep this webinar very, very interactive. So please go ahead and ask questions if you have any. If you have any urgent questions regarding guidelines, go ahead and ask them now. Otherwise, you'll have more time after the case report, and I'll ask Felix to dive into the case report, and then we can have a discussion of the case and also of the guidelines with as many as possible of you. Thank you.
Yeah, thank you, Mark, for the opportunity. And let's just directly dive into this very case. I'm presenting a 78-year-old female patient that presented with shortness of breath and fatigue. She was diagnosed with primary mitral regurgitation. Her past medical history was pretty uneventful, besides arterial hypertension. And this is already imaging data. You can appreciate a classy P2 flail. This is the measurements: flail width 17 millimeters, flail gap 8 millimeters, and that in a dilated annulus, so a pretty severe diseased mitral valve. And I want you to focus on the 3D rendered image in the lower left panel and appreciate that the lateral aspect of the P2 flail appears to be even more diseased than the medial part. Quantification always difficult in severe flails, but if you will, this is EROA based on the PISA beyond 1.0 square centimeter. So now stepping a little back and asking yourself, what is the right strategy to treat such a case? Obviously, residual MR is predictive for future outcomes. We just learned this by the data Amir showed us. So especially for primary MR, in this case where you have a broad flail, what is your strategy? Where do you start with the first device? How many devices are you thinking? And how do you interact with the leaflets? Is it simultaneous versus independent grasping? The goal obviously is a complete elimination and the creation not only of a short-term success, but also a long-term durable tissue bridge is what you want. And I felt like introducing a favorite concept of mine, that if you have a broad flail like this one, which extends 12, 13 millimeters in width, and you have a pronunciation of the flail to either one side of P2, start with the less pronounced part where interaction with the leaflet is easier. And this is what we did just here. So this is central in a lateralized P2 flail. So we're actually acting at the medial part, and to overcome this big dilated annulus, we're using independent leaflet grasping, as you can very nicely appreciate here. And what you can also appreciate is how we nicely stretch and put pressure on the posterior mitral leaflet. Then you interrogate your results. 3D helps. You can see a beautifully created tissue bridge, and color Doppler then gives you the answer whether your concept of tackling one side of the flail was successful. In this very case, we can see as intended that the residual flail is lateral to the implanted device. And then we took a second device, which was much easier to implant here, as we've had some degree of annuloplasty effect, as we've taken away the massive, extensive movement of the PML. And here, simultaneous grasping is sufficient to enlarge the tissue bridge to the lateral side. In this very case, a very nice result with only a very tiny residual jet stemming from the medial aspect of P2. And what I personally also invite you to look at, as I'm very fond of it, is the change in hemodynamic parameters by echocardiography, in this case, the pulmonary vein flow, which was reversed in the beginning, and after elimination of MR was physiologic again. And if you don't believe me, this is a slide I always like to show, as it shows that improvement in pulmonary vein flow is highly associated with a better survival than if you don't change pulmonary vein flow. So you really have to do a baseline and a PV interrogation at the end of your procedure. Now, just 3 other aspects on how we look at our patients and how we evaluate our results, one beautiful tool is vena contracta area by interrogating the 3D color Doppler volume. If you do this up front, you have a good measure of how severe your MR is. And if you do it after TEER, you have a measure that answers your degree of residual mitral regurgitation. This also has been linked to survival, and just to keep one easy number, if your residual vena contracta area is below 0.1 square centimeters, your patients do very well, as opposed to those who have more, or even those who have more than 0.3 square centimeters. Final aspect I would always like to focus on is online pressure measurements. All the systems we work with give you the chance, or you add a pigtail catheter to the left atrium, and if you reduce V-wave, as shown in this very example, your patients do better. There is no prognostic data with relation to hard endpoints, but this is 6-minute walk distance in this retrospective study that was shown to improve significantly better if the V-wave reduction was greater and explicitly more than 11 millimeters of mercury.
Great, thank you very much, Felix. Exciting case and very illustrative of several aspects. We have a lot of questions. Thank you for those. It's great to see that it's so interactive with all of you watching us. Some questions focus, Amir, on the question, well, the anatomical suitability. There's a whole lot of aspects that we have to take into consideration, and this can be quite challenging, in real life. And on the other hand, you have elderly patients, frail patients who are very symptomatic. And what do you tell these patients if they're not completely anatomically suitable for TEER, but on the other hand, obviously quite unsuitable for surgery?
In the end, it's also a question of your own experience of your program. That I think that's something the data shows nicely. And with now nearly 20 years of mitral valve TEER procedures, the experience of the interventional cardiologist has risen, also leading to these better procedural success rates that I've just shown. And that's something that's also highlighted in the guidelines by dividing those that are completely unsuitable, but those who should be treated by maybe some more experienced interventional cardiologists. That's on the one side. On the other side is if you start with the procedure in a maybe complex case, there's always still the opportunity to bail out if you happen to experience during the procedure that there are maybe some unforeseen anatomical conditions that make it more difficult, the gradient rising more than you would have expected. But if you follow the unsuitability criteria, our experience is that you will end up treating a lot of these complex cases with great results in the end, especially despite some presence of complexity criteria. Yeah.
Great, thank you very much. There's also some questions focusing on the toolbox, Felix. And one question we can answer quite quickly, I believe, from a very experienced interventionalist, Jan Ohlik, greetings to you. And he's asking, with this case you just presented, what kind of clip did you use? XT, XTW, Pascal, what did you use?
In this very case, it was a Pascal ACE, or actually 2 Pascal ACE. And I did not underline the aspect, but it was written one of the slides that there was some degree of annular sclerosis. And actually in these cases where pulling on the leaflet very heavily is translated to a sclerotic annulus, I'm happy not to use the device that has the most or the most powerful, the greatest annuloplastic effect, let's put it that way. This is gut feeling, there is no hard evidence on this, but that was my argument to use this device in this very case.
Absolutely, and there are studies ongoing really looking at which edge-to-edge therapy precisely to use which pathology and so on. So I think that's something where we as a community of interventional cardiologists are moving towards, and we have decades of experience now with this therapy, and it shows, and you showed the data from the EXPAND registry and how it has improved as opposed to earlier RCT data that we had.
Maybe I can just quickly jump on what you said, which I fully copy, but besides us interventionalists that have improved, also imaging has obviously tremendously improved. 3D, online MPR, all these tools that help us to better understand and better guide these interventions.
Definitely.
And there's another question coming in. So if it's a very commissurable pathology, is there a certain device you would prefer to use in that kind of scenario?
Yeah, this is a very interesting question, and I've been in many debates, and there's as many opinions as there is interventionalists. Kind of the conventional classy answer would be to be small as you are in the commissure. But I know a program where they actually opt for the biggest device they have because they say, I want to go there once and then get as much tissue I can grasp. And that would be the P10 even. So I think it's tough to give like a general rule. It really depends also on subvalvular structures. And definitely if there's little space, I think the smallest or very small device has an advantage.
Okay, great. Well, we're obviously covering the guidelines and interventional therapy that are recommended by the guidelines right now, but there's some questions coming in, maybe also to you, Amir. What future tools are in the toolbox? Is there something coming up along the horizon of annuloplasty? We do have indirect annuloplasty available to us right now, which might be very beneficial to a subset of patients. But what's your feeling regarding this?
Definitely, also with not only repair but also replacement devices now available, the toolbox will widen further, and this will help us even treating more individualized. Now we are treating most of the pathologies with edge-to-edge therapy, but with more tools coming to our box, this will definitely help us improve our business as well.
Great. And I think actually treating indirect annuloplasty effect through TEER really brings us to secondary mitral regurgitation, where this is extremely important. And Amir, we're excited to hear what you have extracted from the guidelines for us.
Thank you. Yeah, well, for secondary MR, we have now a class 1A recommendation for TEER in secondary severe ventricular mitral regurgitation. Which data is this recommendation based on? Predominantly, of course, we have seen last year the Reshape HF trial presented at the ESC Congress with 3 primary endpoints. Endpoint A was a composite of heart failure, hospitalization, and deaths from cardiovascular causes at 2 years, which was reduced by nearly 40%. Then we have heart failure hospitalization as a secondary primary endpoint, which again was reduced by 40%, and then a very strong improvement in KCCQ group for the device group as compared to control, with a number needed to treat of only 5 patients to prevent one heart event in this cohort, which is really strong data, and as compared to the previous results from COAPT trial and Mitral FR, we have here really the tiebreaker towards the TEER. What else data did we see last year? The Matterhorn trial, of course, comparing interventional therapy versus surgery, where we see a good improvement of MR with both surgery and interventional therapy, with slight advantages for surgery. But we have to keep in mind that a lot of these patients were treated in an earlier phase of TEER with Gen 2 or Gen 1 devices, where these numbers might improve with nowadays available devices. And also on the right-hand side, a good improvement in the NYHA functional class for both surgery and intervention. And if you look at hard endpoints, the primary endpoint of non-inferiority for intervention was met, but on the other side, we have a lot better safety profile for the interventional therapy as compared for surgery. both strong data, which both advocate this and support this Class 1A recommendation that we now have in the updated guidelines. And if you follow the decision tree now for ventricular secondary mitral regurgitation, obviously you have the tier in all the arms at the end as decision and all the anatomies that are suitable and the criteria that are fulfilled. We have this strong Class 1A indication for tier now supporting the interventional strategies.
Okay, great. So if there's no pressing questions, so please, I encourage you all, just put in your questions. We'll discuss them all. I can promise you that. And but if there's nothing really urgent right now, then we'll go into the next case and really see how the new guidelines affect clinical practice.
Okay, happy to present the second case. This is a rather young male patient, 41 years of age, presenting with HFrEF and mitral regurgitation. All is based on ischemic cardiopathy, as he had suffered an anterior and lateral myocardial infarction. He's in functional class 3. He's in sinus rhythm. His QRS is narrow, and he's on maximally tolerated doses of guideline-directed medical therapy. This is his baseline TTE, and you can appreciate the very beaten up left ventricles, only the RCA region that's actually still active. And you have color Doppler information, and it's actually an interesting question. Is this indicative of severe MR, this transthoracic echo? And it's not easy to tell. Like, we're all looking at the jet area, even though we're not supposed to, but here it's not prominent at all. How do you quantify? Obviously, a volumetry of the ventricle is absolutely crucial to get your volumes, to get your stroke, your total stroke volume and your ejection fraction. If you then focus on the mitral regurgitation, on the color Doppler information, and you do your PISA-based measurements, then you demask a pretty prominent PISA area that was calculated or transferred to an ERA of 0.25 square centimeters, a regurgitant volume of 32 millimeters that calculated to regurgitant fraction of 44. And this is with regard to the guidelines pretty far away from the 60 millimeters that are actually required for severe mitral regurgitation. This is the TOE. And here again, the full color Doppler information is demasked. Here you see a symmetric tethering, which you can objectify by measuring the coaptation depth, which is found to be 12 millimeters here. And you can appreciate also in the right upper 3D color Doppler volume that there is color Doppler extending from that very heavily tethered area P2, P3. The indentation is really significantly opened up. So again, what is the interventional strategy? Now we're talking secondary MR, and the same rules apply. Any residual MR is predictive of future outcomes. But where do you start here? What is the anatomic features you look at? How many devices do you use? If everything is centrally tethered, do you start central or non-central? If you start non-central, is there arguments to go medial or lateral? Again, goal is complete elimination and the creation of a durable tissue bridge. And when trying to answer the strategic questions up front, we've mentioned our toolbox. It obviously plays into a role. What tools do you have? And those of us who've been in this field many years now, we've witnessed how a new generation of devices that are broader actually have impacted our strategy. And with a broader device, a clear recommendation is, in many cases, to start with a central position and then go from there, unless you have a very broad jet. In this very patient, we had a huge vena contracta in the intercommissural two-chamber view, as you can appreciate in the upper right box. And again, by looking at the 3D rendered volume in the upper left box, you can again appreciate how this P2, P3 area is tethered. And here we've implanted 2 MitraClip XTW and actually started medially. This is not shown obviously here, but this is one decent strategy to tackle this heavily tethered morphology. This is follow-up of this patient. You see at 4 weeks a very decent result with only little residual MR, and you can also appreciate a significant reverse remodeling of the left ventricle that definitely appears smaller with a better foreshortening. This is the BNP, also supportive of a very optimal course of this patient. Thank you.
Felix, thank you very much for this wonderful case and very impressive results. Also looking at the BNP after several weeks and also checking up by echo. So Ami, may I ask you, do you check with echo all patients you treat with transcatheter interventions, or a large percentage, or what is your current practice?
We try to get every patient back at 6 weeks to 90 days, depending on whether they are on rehab afterwards or not. And also for our quality control, we schedule our patients back at our ambulatory units. Yeah.
What's your practice, Felix?
Same. We see them 3 months after the intervention.
Yeah.
And if transthoracic echo is telling we're good, if there's the slightest hint of a suboptimal result, we would schedule a TOE.
Mm-hmm. Mm-hmm. Okay, great. Maybe before we address one of the other questions, in workup, you showed just very nicely how difficult it is to really assess the severity of these regurgitations, especially if LV function is poor, if the LV is very dilated. So if we take a step back, what should our multimodal workup really be? So where do you see the role of MR regarding volumes, for example? So I can say we do it sometimes, not very frequently, I have to admit. But what about left catheterization, right heart catheterization? How important is that?
I mean, left is kind of a regular reflex of any cardiology to interrogate reduced LV function. I think there's no doubt that this is a well-indicated procedure. I'm very fond of doing a right heart catheter on top, also in the mitral patients. I think it was kind of out of fashion and entered back into our cath labs via the ambitions to treat tricuspid valve, and now looking at the wedge pressure and the V wave before a mitral intervention, I think is absolutely helpful, especially in doubtful scenarios where echo is not very decisive. If you then have a patient that has a completely normal left atrial pressure, I think you have a good argument to step back versus you demask a high V wave and a high LIP. Then you do have an argument to treat MR if medically everything is done. So echo, invasive, diagnostic, and I play the card of right heart cath also before mitral interventions.
Maybe what we can add is also right heart catheter is a good tool if we are on the other side where we have advanced heart failure and we are thinking about maybe transplant LVAD therapy as an alternative to decide which is the good patient for a TEER procedure or which patient should go another way in advanced heart failure.
Yeah, I think it's probably we can agree that the guidelines now stress also using CT coronary angiography in selected patients, but probably in AV patients, so mitral and tricuspid patients, this is not as valuable as in aortic patients, maybe because we oftentimes need the left heart catheter anyway, and it's always very helpful to have the right heart catheter. So I think that's something that has to be taken with a grain of salt regarding the AV problems. There's another question which is very interesting, and I would like to address this to you, Amir, about dynamic MR. So how do you go about assessing dynamic MR, and what do you think is really the importance of dynamic, and what's the response if you treat dynamic MR with TIA?
So we test for dynamic MR routinely whenever we see a moderate MR and the patients are symptomatic, and we have the feeling from the clinical expertise that we are missing something with a moderate MR. And we have a hand grip at every echo machine we have in our clinic, and we really frequently using this tool, and we demask quite a few severer MR cases. And if you, for example, look at the extent data comparing moderate to severe or severe MR treated with M-tier, we see a very good remodeling effect, especially for the moderate MR cases. And I would guess that a lot of those are indeed dynamic moderate to severe or severe MRs that are just graded at moderate at resting echoes. Mm-hmm. So this is really an important tool in our clinic to use dynamic echocardiography images to check for dynamic MR.
Okay.
What exactly do you do? Is it a hand grip?
Hand grip. It's easy. It's the most easy and for the patient not too complex as well to follow, even for a, let's say, elderly patient. We also do have a bicycle that we can tilt on left side for these purposes, but the routine really is hand grip.
And how's the protocol exactly?
It's 3 minutes of hand grip that the patients can do. We do a blood pressure at baseline as well to get an idea of how that changes, and resting heart rate, stress heart rate, to see whether the patient's really in some physical condition.
Interesting.
Yeah. So, and also I think all of us work very closely with cardiac surgeons. So Felix, in this last case with severe LV dysfunction, I think it's important to have the surgeons on board also early on to discuss, is this a patient for LVAD therapy, heart transplantation, and so on. So what is your practice in this regard? Are they referred to like an LVAD special clinic or something where they are seen regularly to evaluate this further?
Yeah, absolutely. A good question. Also in this very young age, so everybody like presenting a patient this young in a heart team is provocative to a certain degree. On the other hand, if you then discuss treatment therapy options, and there's not too many for this patient, and we all are familiar with the concept that you may call bridge to LVAD, bridge to transplant, and some of these patients do extremely well on TIR, but very importantly, they need to be followed up very closely. So it's really not a fire and forget situation, but if you treat someone with such a bad ventricle or even advanced heart failure, you need to see them very soon after your intervention and offer them a clear perspective. And if you happen to work in a center where there's a heart surgery on site and your partner and they have an LVAD clinic, then that is something to also consider and to also discuss on a regular basis.
Right, absolutely. So, and there's another question coming in, and this was we alluded to just earlier. Obviously, in secondary MR, mitral ring dilatation is a huge problem, be it ventricular or arterial. We'll be coming to the latter point a little later. But so what are our options right now? Obviously, we do have the option of indirect annuloplasty, and in our center, we do use this for a select group of patients with very good results. But what do you see, Amir, on the horizon? What kind of approaches do we have for annuloplasty? What might be coming?
Again, with the devices we have and also with the larger devices we have for TIR, the annuloplasty effect has improved over time, and the wider, so there's also something we can do there. And for the replacement therapy, M3 coming up, the ideal patients might also be those with a functional MR with large ventricles and some tethering as well. So this might be an option for those cases as well.
Right.
It's really also what I'm thinking, because you have secondary ventricular MR patients that do have dilated annuli, where dilation significantly adds to the lack of coaptation, but there's others where you do not have a significant dilation and where annuloplasty, to my understanding, really doesn't make a big difference. You may even increase your tethering angles and decrease coaptation. So in those, I would either see TEER as a really relevant part or column of our interventional therapy, or as you said, the complete valve replacement. You obviously have to go into the morphology very specifically, and depending on how the posterior leaflet segments interact, whether you have deep indentations or shallow indentations, this all impacts your residual opening area, which is also predictive of further clinical events. So I would be pretty sure that if valve replacement has become a standard intervention, as a significant degree of those severe ventricular secondary MR patients shift. We do have parameters that predict less optimal results, like a very heavy tethering angle. So,
Sure.
Many interesting therapies to come.
Sure, and with valve replacement coming up, we'll also have to look for parameters that will predict maybe not so optimal outcome in valve replacement and valve repair. As we know from the surgeons, valve repair, especially in LV and reduced LV function, is oftentimes superior. So, and you alluded to the widening toolbox that we have and the different TEER devices that we have, the indirect annuloplasty device that we have, so that we can really look at each patient individually and see whether we need maybe even a TEER device with a spacer, for example, if you're concerned with the opening area, for example, or if you want a TEER device that really has maximal annuloplasty effect, as we just alluded to earlier. So I do think it has become much more tailored to the individual patient as compared to a few years ago.
Just maybe one addition, surgical annuloplasty is, according to the guidelines, no longer standard of care for the majority of the patients, at least once the ejection fraction is below 50%. So that's also something to stress with the new guidelines, that in the end it's either interventional therapy or in advanced heart failure, LVAD or transplant, but there is no recommendation regarding surgical reconstruction of the valve.
Right.
I also think, I don't think reconstruction is really a good term, right, for surgical annuloplasty. I mean, it's beautiful and highly efficacious in primary MR, but secondary is a different cup of tea.
Absolutely. Okay, so I think we'll move on. We have another further aspect that we alluded to just earlier, and that would be secondary mitral regurgitation, but atrial secondary mitral regurgitation. And Amir, if you can take us through a few aspects from the guidelines.
Yeah, that's another key feature that's novel in the new guidelines, that besides the ventricular secondary MR, we have this new phenotype, what's well defined now as atrial secondary mitral regurgitation. And it's reflected also often in the patients with, for example, atrial fibrillation or HFpEF, where you have these largely elevated left atria, and at the same time frequently preserved left ventricular ejection fraction with no or only mild dilatation of the LV cavity. Usually these qualify also by normal leaflet motion and leaflet morphology, and usually central jet. Of course, there's also some overlap between the atrial and the ventricular, with patients having both, or with the ventricle due to the regurgitant volume, the volume overload dilating, also in the atrial phenotype. But at least this is the first time that the guidelines are picking up this specifically. And there are also diverse recommendations for this subtypes. Recommendations are not as strong as for the ventricular SMR, also based to the fact that we don't have randomized controlled data on this phenotype of secondary MR. But we do have also some registry data, both for TEER on the left hand here and for surgery. The TEER data is also pretty new, so it might not have been taken into account for the current guidelines, because it was published just also a couple of weeks ago, comparing in a propensity score matched fashion medical therapy versus TEER here on the left-hand side, with a hazard ratio of 0.58 for all-cause deaths, and on the right-hand side, it's a comparison of surgery and medical therapy, again with a probability of survival and strong signal towards the surgical arms. And what's interesting about these two data points that I picked out here is that they are both on very similar, or maybe even partial identical cohorts.
Okay, thank you, Amir. That's a very interesting new aspect of the guidelines, I think, and that has been raised. And obviously, there's not as much data as you alluded to, and also it could encourage us. And there are several studies obviously ongoing to address this question. And there's a question actually from the audience, and I think this is exactly what we're talking about right now, and that is whether patients with HFpEF can improve from MR interventions, and obviously these would fall largely, not all of them, but most of them would fall into this arterial secondary mitral regurgitation group. And obviously also we have quite a lot of let's say common ground or overlap between ventricular secondary MR, arterial secondary MR. So it's even in the guidelines, it's not as clear cut as what one might think. And so now, Felix, you have another case prepared for us, a very nice case regarding arterial secondary regurgitation. We're happy to hear about it.
Okay, let's jump into it. This time it's an 80-year-old female patient with heart failure in functional class 3, and she was diagnosed with severe atrial secondary mitral regurgitation. Past medical history was positive for long-standing, year-long persistent atrial fibrillation and arterial hypertension. BNP, interestingly, not very elevated. Reduced kidney function, hemoglobin was okay. And before we jump into this case, we felt to inform you that even atrial secondary MR has different phenotypes that are relevant to understand. And in this state-of-the-art paper, which we've taken this nice drawing from, two phenotypes are introduced. The left one, which is called normal, is kind of the classic conventional atrial secondary MR logic as it is introduced also in the guidelines. But you can have a much more pronounced version of atrial SMR where it comes to tethering of the PML and the pseudo-prolapse of the AML, which is not so easy to understand up front, but also the guidelines mention this pathomechanism and even state that it has been falsely interpreted as actually primary disease as a AML prolapse, but in fact it is the pseudo-prolapse. And as underlined here with this blue arrow, an ongoing progression of the annular dilation leads to a pivoting of the PML and that PML tethering. All of you, I mean, the ones that know this can recognize well. The ones that pick it up today will be able to recognize this from now on and never forget. It's an impressive pathomechanism. This is our female patient. I think a full-blown picture of atrial secondary MR by atrial dilation, a big eccentric jet towards the lateral wall of the left atrium, and an enormous PISA that calculates to a regurgitant volume of 134 milliliters. This is morphology, again by TEE. You can appreciate how big this left atrium is and how dilated the annulus IP dimension is, close to 5 centimeters. You can see how open those indentations are between P1, P2 and P3 in the left lower. 3D rendered volume. And again, you see this really impressive color Doppler jet information. And even this, if this is not like the full-blown pseudo-prolapse situation, you can appreciate that the AML is starting to slide over the tethered PML. This we have addressed already, these very prominent indentations. Mitral valve open area, 10 square centimeters. And this is the intervention. We've discussed what device of our toolbox to use. This would obviously be a situation where I opt for a device that gives me a very strong annuloplastic effect. Here again, independent grasping. Where else if not here? And we start obviously with the anterior leaflet and then swing to the posterior leaflet and get a good grasp, as seen here, right image of the posterior leaflet. This is the result after the first of the deployment of the first device. We've started slightly medially, so there's a lateral jet stemming just adjacent from the implanted mitral clip. And then obviously discussion is where to put the next one and how close do you want it to be adjacent to the first one. And here, so we dive into the ventricle with a little distance to the first device and then really try to make a close contact with the first device to create a very stable central tissue bridge. Would we expect a perfect result in this huge annulus? No. It's obviously difficult, despite the pronounced annuloplasty effect, to fully close these open indentations. And this is why there's jets stemming from these indentations medial laterally. But this is all TEER could do. Here again, before and after by 3D echo, and as you've realized, very fond of pulmonary vein flow patterns. In the first place, before left lower panel, there was no systolic forward flow, and after TEER, it was completely normalized in the upper left pulmonary vein. And this is the gradients before and after, so upper row is before, and you already had, despite this huge mitral valve area of 10 square centimeters, we had a mean gradient of 6, giving you an insight on the huge amount of regurgitant volume. And by echo, we had an RV-RA gradient at baseline of more than 50 millimeters of mercury. And after the procedure, we went down, we only elevated the gradient by 1 millimeter of mercury. And as a explicitly good sign of a hemodynamic improvement, the RV-RA gradient was significantly reduced to 35 millimeters of mercury. Complex case, fair result, but a challenging morphology.
Thank you very much, Felix, for this excellent case. Really very interesting case. And I think there's lots of points that one can illustrate here. One point you raised is the gradient. So the gradient to begin with was quite high due to the large regurgitant volume. And so there's a question also from the audience. What would your strategy be, especially in secondary atrial MR, if you encounter, let's say, a gradient increase by 3 or 4 millimeters with the first clip? Are you bold enough, so to speak, to implant the second clip if need be? Or are you very reluctant to do so? What would your strategy be?
I mean, this is not a question that applies only to atrial MR, and it's never really easy because you want to eliminate MR, but you also know you don't want to create a gradient. So sometimes this can be very tricky. And one answer to the question is to kind of set aside the hemodynamic approach that echocardiography gives and just really measure morphology, do a 3D volume, and then measure the opening area. There is data that if you stay beyond 2 square centimeters of opening area, your patients do well. So that's probably the best answer I can give. I mean, 5 is the rule of thumb, which I think is decent. There is significant data that beyond 5 patients don't do well. Even though if there's conflicting data, but I don't know. I've seen these patients that had a high gradient that did tremendously bad. So you really can't create a stenosis.
Sure, but one thing I think I would encourage everybody to try is really, you can always, take back the clip or take the clip back out. Sure. So I would suggest, place a second clip, see how it affects regurgitant volume, because obviously if you bring down regurgitant volume, you will also bring down the gradient, right? And that's exactly what you did. In your case, you placed 2 clips, XTW even, so with a huge annular effect we would expect. So the orifice has become significantly smaller, but your gradient only increased by 1 millimeter of mercury. So obviously, regurgitant volume was decreased massively. So, and this outweighed the decrease in orifice area. And so I think that you should always give your patient that chance by really placing a second clip if necessary, obviously, or even a third clip, and see how you fare with your gradients and with regurgitant volume, obviously. Amir, you wanted to add something?
One additional aspect is if you're going really close to the first device, the reduction in mitral valve orifice area will not be as big as by the first device if you go close to it. If it's a second pathology that's on another position of the valve, or you want to leave some gap between both devices, then obviously it will be a completely different thing where you will end up with higher gradients afterwards. But just 2 narrow devices next to each other, maybe the rise in gradient will be not as big as you would anticipate from the first to the second device.
Right, yeah. So, and one other aspect also in your case is that you had also lateral and medial of your bridge, you had some, let's say, leaflet defects in the posterior valve. And so indentations, augmented indentations, whatever we want to call it. So looking at the gradient, probably, would you say going for these defects with another device in addition, would that be something that is prudent in your eyes, or would you be cautious?
Yeah, to my understanding, another TEER device would not have helped. But if annular dilation is the primary problem of the very pathomechanism, then a more explicit form to do annuloplasty would be helpful, no? To just decrease the whole annular area, and by that closing also these indentations as the leaflet to area ratio is improved. So this would actually be a case where I'd love to do a combined procedure of a direct annuloplasty and TEER. I think that would be beautiful.
Absolutely. Absolutely. Yeah, great. Then maybe one thing we can clarify, there has been some confusion because you just showed the RV gradient as an important, and it is a very important hemodynamic outcome measurement that you performed. But if you could just allude to what is, in a little more detail, why are we concerned with the RV gradient after treating the mitral valve?
It reflects the pre-cap part of pulmonary pressures, and why would it go down after treating the mitral valve? Because you significantly reduce LA pressure, which then stops the backfire through the pulmonary capillary bed to the pre-capillary part. So this is how I would interpret this, and this is what I meant. I've realized these also during tendine procedures where we've really treated horrendous MR, and even wedge pressure went down. So as a enormously positive sign of improving hemodynamics.
Yes, and Amir, when we were discussing earlier, you mentioned that when you're evaluating actually tricuspid regurgitation, which is not the topic today, but that you're very fond of getting to the wedge pressures and then looking at the V wave and so on, and really identifying patients with maybe moderate to high grade mitral regurgitation. Could you explain a little more what your thinking is on that topic?
Yeah, for sure. Before we treat tricuspid valve disease, we want to be sure that the post-capillary pressure overload that's coming to the right ventricle is treated if there is any. So we are very, very much looking into the pulmonary wedge pressure to see whether we have a high V wave. And if we experience a high V wave in combination with a moderate to severe MR, we would for sure treat that first, and hope that if we go then for a staged procedure of the tricuspid valve, 3 months later, it might not be torrential anymore, but just massive or severe. Right. Definitely something to do beforehand then, yeah.
Absolutely, absolutely. So, and there's another topic coming up which we've only touched upon very briefly so far. That is how to proceed with moderate secondary MR. What are our options in secondary moderate MR that is highly symptomatic, and the cases given here are with frequent hospitalization due to heart failure. So what would your feeling be, Felix? How should we treat these patients?
Excellent question, of course, and not very easy to answer. First of all, I'd be looking at the quantification of MR, which is in secondary MR not always easy. So what is potentially moderate by guideline may in reality already be hemodynamically relevant, as regurgitant fraction is close to 50%. So we can have an ERA of 0.2 and we can have regurgitant volume which is low and still have severe MR. So maybe it's misclassified in the first place. One relevant point, I think. The other point is that if it is, that's a very pragmatic answer, if you really have done everything for this patient, he's on best medical treatment, rhythm is taken care of, volume management is excellent, what else can you do? And we are so safe and titrating with our TEER procedures that I would say, okay, let's discuss with the patients what is in the game, we can't promise obviously anything, we never can. In this very case, it's even more difficult to predict the impact, but I'd be happy to say, okay, this is moderate MR, let's give it a shot.
Great.
And definitely this is also a case to check for dynamic MR in these cases.
Absolutely, sure. Yeah, that's a very strong point, absolutely. And I think we can all be very hopeful that there's data coming up, addressing specifically this question, also maybe taking the volumes into focus a little more on how we can affect volumes and remodeling of the left ventricle with these therapies and improve outcomes of our patients via this route. So this is certainly something we will all be very excited about for the future. Well, thank you very much. I would like to wrap up this really fantastic webinar. First of all, by thanking Felix and Amir for excellent presentations, and by also thanking all of you for your valuable questions. And this has really been a very interactive webinar. We have addressed the current evidence from randomized controlled trials and registries on mitral interventions. So how did this inform the guidelines right now, but also what is in the pipeline, so we can be hopeful for further developments. And some very important aspects, I feel, in the challenges and how do we best select our patients, looking at hinge points in the annulus, looking at dynamic MR, and really looking at the gray areas between atrial and ventricular secondary mitral regurgitation, also looking at the really challenging cases we have in primary regurgitation, but with our increased toolbox that we can really treat very well interventionally these days. So that's something which also has to be kept in mind when discussing these cases in our heart teams. And we also looked at specific procedural approaches. We had quite a few colleagues joining us who had very specific questions on which clip to use and what kind of modifying approaches we have for the annulus and so on. So I think the specific procedural approaches, depending on etiology, is also something that is really very important. So with that, I would like to thank you all again, and we're looking forward to further exciting PCR webinars. Thank you very much, and goodbye from Paris.